All right, Madam Speaker, are we ready to?
Yeah, you're starting off.
Oh, let me fix my sound here just a moment. All right, hopefully that did it. We'll see. All right. Good morning, everyone. We are back again. Hope everyone had a at least pleasant holiday weekend and is enduring the heat that we are all experiencing here. Only have a few opening comments before I hand it over to the speaker this morning. The first is probably the most important and is something that has an increasing level of urgency and has to do with the elections upcoming in November. Certainly, I'm sure a number of us saw the notice of the State Board of Elections making recommendations with 3 different options for how the elections could be run. I think the core message here is that no matter which option is chosen, the bottom line is a decision must be made. Each day that we continue forward without a decision creates more and more a higher likelihood that we will have problems this upcoming election. Certainly, the chair of the Education, Health, Environmental Affairs and I sent a letter to the State Board suggesting our preference around a mailed ballot. But no matter what, local boards and the State Board need to know what the decision is so that they can start planning. And every day that a decision is not made is a day lost that puts the election in greater jeopardy. And so, we still are in a state of emergency. And just would like to very much urge the governor to act as quickly as possible to make a decision, because this is going to be a very, very important election. And the sooner that decision can get made, the better it will be for all Marylanders to have a greater period of timing. We have an interesting set of speakers today, very much focused on health and the long term here. I think it's really important to note that we're seeing very positive trends in Maryland. And this is largely the product of Marylanders making very smart and thoughtful decisions, using masks, practicing good behavior, social distancing. And we've seen the opening up of our economy, and we've seen our numbers really start to level off and not see this type of uptick. Unfortunately, I think what we're seeing in a number of other states, in Florida, Arizona, California, Texas, those trends are not the same. And so it's this very important moment in this experience where Maryland, having made some very, very difficult decisions early on, is now sort of faced with looking around us and seeing a varying impact. And so today I look forward to hearing from both the Department of Health and from members of our academic community, but who are looking at projections with updated data about what the long term of this could look like. I will say that one thing that I look forward to hearing from the Department of Health is about contact tracing. We know that there has been an effort engaged upon, and that the state has worked rather diligently to try to put together a contact tracing program. We know that there are counties like Anne Arundel County who have really been out front and dove in very quickly with contact tracing program. The Washington Post recently did a story that Maryland was one of the few states that did not have contact tracing data available publicly. I think the coronavirus website has really done a great job of talking about some of the testing results. I think sort of the next phase as we continue in this monitoring process will really be to add those additional rich data about contact tracing, how many people are being contacted, how successful are they being, because this is what's going to be so important for restoring trust and faith in the future as we experience this all together. The last note is sort of an international note, and it's something that Jake will joke about quite a bit, because I think I bring it up every day, that I am continually frustrated by this division between economy versus health, that fundamentally they are the same exact thing, that we will not be able to restore our economy until there is both the actual public health being achieved and the perception of public health being protected. Those two concepts cannot be separated. And I was, this weekend, there was a report based on Sweden. And early on, Sweden made some of the choices to not lock down as much and to keep kids in schools. And the most recent economic quarter, they are behind their other peers in economic output. And it went to show that sort of those early thoughts of lockdown kept them stronger for their economy. But it turns out, kind of as you fast forward through the period, they were hurt as much, if not more, than some of their other peers who made some more intense decisions. And so I just think as we move forward throughout this longer process, we've got to make sure that we are not looking at health and the economy as opposing forces. They are one and the same as we face this pandemic. And with that, would like to hand it over to Speaker Jones.
Thank you, Mr. President, and good morning to everyone. Mr. President covered a whole lot, so I want to get right into why we are here today, who we want to hear from. Now, as Maryland continues to fare better than many other states, I just want to underscore to everyone the importance of social distancing and wearing masks, both for your families and also, and stress that in terms of your constituents. We must remain vigilant in order to keep our families and communities safe. As the agenda is up, we're going to go to our first presenter, and that is Dr. Clifford Mitchell. He's the director of the Environmental Health Bureau at the Department of Health. And he is our go-to public health expert when it comes to reopening. We've all seen the resurgence in other states because they've reopened too quickly. And we know that young adults under 35 are driving the increase in positive test rates. Northern Virginia had just gone into phase 3 of their reopening. And we've asked Dr. Mitchell to talk to us about the department's efforts to handle cross-state COVID-19 cases and what we're doing to encourage responsible behavior, particularly among young adults, but others as well. Dr. Mitchell, please proceed with your presentation.
Good morning, Madam Speaker, President Ferguson, and members of the work group. Thank you for the invitation to be here. My name is Dr. Clifford Mitchell, and I'm the director of the Maryland Environmental Health Bureau at the Department of Health. It's an honor to be here to address you on the important topics that you and the President have discussed this morning, and I want to bring you up to date on our latest activities and progress in the ongoing response to COVID-19. Since our last report to you, and thanks to the incredible sacrifices that you have mentioned of Marylanders across the state who've engaged in social distancing and the wearing of face coverings, we have largely had a downward trend in the number of positive COVID-19 cases and in the overall COVID-19 hospitalizations over the past month. However, as you both have noted, this crisis is not behind us. It is important to stress, as you have, that no Marylander is immune from this virus, including those under 35 years of age. And we continue to strongly recommend that all Marylanders practice social distancing, use of facial masks, facial coverings, and that they avoid large gatherings. And as you have indicated, our long-term recovery can only be effective if we continue to exercise personal responsibility and follow these recommendations. So as of today, and I think if you can advance to the next slide, thank you. Our number of new positive cases is 465 for a total of 70,861 cases cumulatively. And we've had 9 new deaths with a total of 3,149 deaths in the state of Marylanders. We have 398 total COVID-19 patients hospitalized. 262 of those are in acute care and 136 are in intensive care units. This morning, our statewide positivity rate is 5.23%, and our 7-day rolling average positivity rate is 4.61%. Since our June 18th letter to county leaders, when only 3 counties had tested over 10% of the population for COVID-19, those 3 being Somerset, Wycomico, and Dorchester, we now have 11 jurisdictions that are over 10%, with Montgomery County just below the threshold of 10% at 9.9%. We have largely sustained 10,000 PCR tests a day in testing volume through the month of June, and we're happy to announce that we believe we have sufficient daily lab capacity in Maryland to extend testing on demand for any Marylander who wants or needs it. As we've looked at both the data in clinical reports related to COVID-19, we continue to emphasize that people of every age need to be following good public health practices, including facial coverings and social distancing. We have noted a shift in positivity rates, which initially were much higher in older people, to now a slightly higher positivity rate in younger people. While this is due in part to the success of prevention efforts in older adults, it is clear that COVID-19 can cause serious illness in young people, and we have continued to stress the importance of prevention at all ages. Our focus over the next few weeks is to encourage all Marylanders, including those under 35 and in those in vulnerable rural and minority populations, to first wear a face mask as much as possible when out in public places. We've launched a public awareness campaign that highlights face coverings, do's and don'ts. And for more information, you can see our social media effort at #MasksOnMaryland. We urge you and every member of the General Assembly to help encourage every Marylander to wear a face mask. Please help us get this message out and ask your networks to join in the #MasksOnMaryland campaign in order to reach the largest number of people in the state possible. A secretary's order was issued last week that allows testing on demand. It now provides that any healthcare provider is required, if permitted within their scope of practice, to issue a COVID-19 lab test order on demand by a patient. We've also encouraged individuals who are symptomatic, asymptomatic individuals in certain broad close contact categories, and those who've returned to or traveled to Maryland from out of state to get tested. And in addition, we're working through 9 Maryland Medicaid managed care organizations to get the word out to Maryland's 1.4 million Medicaid beneficiaries that everyone can get tested for COVID-19 and not have to worry about paying for it. We are working with our colleagues in the Maryland Insurance Administration to further expand testing among the commercial insurers, and we are launching, both this week and last week, high volume testing sites in tourist hotspots at Deep Creek Lake and at Ocean City. In addition, a new statewide public service announcement and social media campaign will urge anyone who may have been exposed to get tested, and we welcome your participation in this public outreach effort. My public health epidemiology colleagues and I are keeping a careful eye on the data as we receive it, as we move forward carefully and cautiously on executing on the Maryland Strong Roadmap to Recovery, at which point every step we take on issuing guidance has been in consultation with our colleagues throughout public health, the Office of the Attorney General, the Maryland State Police, and the Department of Commerce. Currently, we are not recommending that a mandatory quarantine for out-of-state residents be imposed. We believe that careful testing and contact tracing investigation method is the most likely to yield the best balance between public health needs and our constitutional rights to interstate commerce. And again, we recommend that those coming from out-of-state travel, particularly if they have been in situations where they feel they may have been exposed to COVID-19, to get tested for COVID-19 so that they can protect both themselves, their families, and those they visit. On the contact tracing front, since we launched, and I apologize for the siren if you're hearing that in the background. On the contact tracing front, since we launched in early June, we've been largely successful in our initial goals and are working on improving our contact tracing system. Statewide, from June 20th to July 3rd, we've had 5,385 newly reported COVID-19 cases. Of those, 5,187 cases were entered into the COVID link system for contact tracing. And 2,867 cases completed the interview. 15 hours was the median time to interview from the time entered into COVID link to the time of contact. And 2,175 cases identified at least one contact for follow-up. We continue to urge all Marylanders to pick up the phone when COVID-linked calls and to help protect their neighbors and community by fully participating and helping the contact tracing investigation. We have also launched a statewide outreach and awareness campaign to urge Marylanders to cooperate when called. And as we monitor the national situation, we will take additional steps as necessary. However, we believe if Marylanders continue to take common sense steps to protect themselves and their neighbors and their families, we will get through this pandemic together. So in finishing up, I would just urge you all, please wear a mask, practice social distancing, get tested if you have concerns, and if you get called by Maryland COVID, please pick up and help the statewide effort to reduce COVID-19 in the state. With that, that concludes my formal remarks, and I'm happy to take your questions. I believe you're on mute.
Madam Speaker, I think you may be on mute.
Sorry, Madam Speaker, I think you're muted.
Oh. There we go.
All right, the host had to have done that, just saying. All right, we have a first question from Vice Chair Jackson.
Very much, Madam Speaker, Mr. President. Thank you for the presentation. Two quick questions. Dr. Mitchell, you know, there's a Department of Health put out a document on June 9th that reflected the PPE distributions for local jurisdictions. I represent parts of Prince George and Coward County. In Prince George's County with its numbers, you know, it was a glaring disparity in the distribution. Now, I apologize if you're not the person that I need to be speaking to, but we have been seeking to catch up with that distribution. Prince George's County had 3 times less than Baltimore City's PPE distributions and 2 times less than Baltimore County and Montgomery County, which seemed quite odd for a county that had such cases. That's regarding PPE. If you could comment on that, I'd appreciate it, or if you could direct us. I know that our county folks are seeking to be prepared for the fall anticipated surge and hopefully not a premature surge. And secondly, if I might, Madam Speaker, very quickly, contact tracing. I know in Prince George's County, we're using our public safety investigators due to our inability to have face-to-face contact with a lot of hiring prospects to add to the contact tracing teams. Is that something that you're seeing across the state, or is that just unique to some locales? Thank you.
Thank you, Delegate Jackson. So I can partially respond to your first question related to PPE distribution based on an answer that we provided to Senator Griffith earlier with the same question. The lower number of PPE distributed to Prince George's County was because the request that we received through what's called Web EOC, which is the communications pathway for local governments to request PPE. That request from Prince George's County was lower in total numbers than in certain other jurisdictions. So we did fulfill the request from the counties as we received them, including that request. And we have, in fact, within the department, been prioritizing PPE to the most affected jurisdictions, particularly Prince George's County. So while we have not received, at this point, specific reports of PPE shortages, certainly if there are issues that need to be brought to the department's attention, we would appreciate knowing those. But that was the basis for the original distribution.
Interesting. Thank you very much.
And could you repeat your second question again, just so I understand exactly what it was?
Well, yeah, the contact tracing in Prince George's County, we're using some of our public safety investigators since they aren't able to go out to do face-to-face interviews. We're using them to do contact tracing within the county regarding our cases. Is that something you see across the state, or is that coordinated with your office?
Yeah, so there are a variety of different answers to that depending upon which jurisdiction you're talking about. In some of the larger jurisdictions, the local health departments have taken on the primary responsibility. They may or may not do that in conjunction with other with other local agencies. In some of the jurisdictions, the National Opinion Research Corporation, NORC, which is the contractor for contact tracing, is making the primary contacts telephonically. And then if there's a need for follow-up, that may be done locally. So it depends which jurisdiction you're talking about. There is a variety of models depending upon which jurisdiction.
Thank you.
All right,
Thank you.
Chairman Pinsky.
Thank you, Mr. President, Madam Speaker. Dr. Mitchell, welcome. Good to see you. A couple of questions on contact tracing as well as quarantine. It's my understanding that with contact tracing, you can look at new cases that are linked or not linked. So you can sort of isolate where the new cases are coming from, whether other people are spreading it or not. Are you keeping those statistics, number one? And number two, do you plan on putting them on the dashboard? I know some states are putting up metrics on contact tracing to see how effective it is, how many how many contacts are made when your people actually reach out to the contacts, but also looking at linkage. So that's my first question. The second one, or my first area of questions, the second one is about quarantine. You know, and you know this better than most of us. In some communities, I'm going to use the Latino community or Latinx community, you have multi-generational families living in a small apartment. Someone comes down with it, it's very easy to spread it to others. Have you at all been considering, or maybe you already have, directing people to hotels and offering food and isolation so it doesn't get spread further? Obviously, there's a cost to that. Hopefully the state could pick that up. And how extensively are you using some kind of quarantine available hotels and food services?
Thank you, Chair Pinsky. It's nice to talk to you again. So let me take those in order. So with respect to the dashboard, we have, in fact, the COVID link platform does allow for some very sophisticated metrics. We are working with our team to put together a public-facing dashboard on contact tracing. We recognize it's an interest not only of the General Assembly, but also of the public. So we hope to do our internal homework by next week and have a public-facing dashboard shortly thereafter. So we do recognize and acknowledge the great interest on the part of the General Assembly in seeing those numbers, and we intend to follow up as quickly as we possibly can. With respect to the kinds of data that we can get, yes, you are correct. It is possible to look at which contacts people have, and we are very interested in those as well. The issue of quarantine, as you yourself have alluded to, is not simple. It is remarkably complicated. So just if I can digress for a second. So obviously, one of the things we are hoping to do and we are trying to do is make sure that we contact as many people as we can as quickly as we can, because the studies that are related to contact tracing show that the more people you can reach and the sooner you can reach them, especially the sooner you can reach them, the more effectively you can get them to self-isolate either at home or elsewhere. Now, our first preference is obviously to get people to self-isolate at home. And that is what the vast majority of the self-isolation is in most cases. There are cases, and I can't give you specific details of those at this moment, but there are cases when it may not be possible or advantageous for people. They may be homeless. They may have, there are a variety of situations where that home may not be the best environment. We recognize some of those relate to people's individual circumstances, and in some cases, people do not have a home. And I'm aware that local health departments in some cases are using alternative venues to house people. That is true for a variety of agencies. I can't give you numbers at this point, Chair Pinsky, on how many of those there are, but it is certainly something that our Office of Preparedness and Response, local health departments, and others have had conversations about with respect to particular populations, including people experiencing homelessness. So I cannot provide you specific details, but I will say that it is absolutely something of which we are both aware and trying to address in every case in which it's clear that a person may have difficulty going home and socially isolating.
Right. Let me do a quick follow-up if I could, Doctor. Look, the homeless, we understand people without a home. I guess I'm concerned about a situation where you have maybe 5 or 6 or 7 or 8 people living together.
Sure.
The contact tracer will say how many live in your present apartment or home.
Yep.
People might be uncomfortable in answering that question because people are suspect, and also if they're people over 50 or 60 or 70. It seems to me making it clear there's another option.
Yep.
And that they will not have to pick up the tab, and they'll have pretty decent circumstance, again, whether it's a Marriott or a Super 8.
Sure.
And also food will be available. That tension of wanting to isolate people and quarantine, with people being a little nervous about answering that question and saying,
yep.
Particularly with people who are having come from an immigration situation, that seems like it's a little more complicated and has to be a little bit more nuanced.
So I totally understand your question, and let me give you a personal experience of this that may help explain some of the challenges. I was significantly involved in the response to poultry processing concerns on the Eastern Shore, and involved with the department in the large-scale testing that we did and contact tracing with the Wicomico Health Department and the Dorchester County Health Department. So we actually had a series of conversations, not only with the local health departments, but also with Delaware about this exact issue, because that is a population which it was very, very significantly Haitian Creole and Hispanic. And so exactly the concerns that you raised. We did, in fact, the local health departments actually did, in fact, make a concerted effort to identify and provide to people who were concerned because they were living in large-scale congregate housing situations, alternative housing. And the interesting phenomenon that was observed both in Delaware and in each of the counties was that for the most part, people's preference was not to take them up on that offer, but instead to live at home. So I think, part of the challenge that we face, and just to be frank about it, is where the counties have attempted to offer that, and in many cases made significant arrangements to have alternative housing arrangements available. People's choices in many cases have been to actually isolate at home with their families. So that's part of the challenge.
Okay, thank you.
You're welcome.
Majority Leader Lukey.
Thank you, Madam Speaker, Mr. President. Dr. Appreciate you taking the time to talk to us today. I'm curious, so I know we shouldn't read too much into the day-to-day statistics, but it does seem like our daily case count had eased off significantly, but plateaued, and now it looks like we're easing back above 400 new cases in our 7-day moving average. My question is, in the first part of the pandemic, we saw a lot of issues in nursing homes. Do we have a sense of where these new cases are coming from? Is it what we're seeing in other states where we're having clusters among young people, or is it just sort of noise within the data right now? Yeah,
thank you, Delegate Lukey. So 2 things about that. First, As you yourself said, I'm always cautious about reading too much into any one short burst of numbers. So we really do look for longer term trends. So I appreciate your thoughtful approach to that, and agree with you that we look at the numbers every day, and I find myself biting my own tongue to try to make sure that I don't read too much into each of the numbers as they come hot off the press. So I appreciate your thoughtful approach to that. With respect to where those cases are coming from, I think the one thing that we've said, again, they tend to be primarily from the National Capital Region and Baltimore, with a slight increase in the proportion coming from the Baltimore region, as opposed to what historically had been earlier the National Capital Region. But that's still, as the population centers are where the majority of the cases are, followed by Southern Maryland, then the Eastern Shore, then Western Maryland. In terms of the biggest distinguishing characteristics of the new cases, the fact that they are shifting a little bit towards younger people is probably the most one of the most noticeable epidemiologic trends. So I think that we have continued to see just slightly a widening of that difference in the positivity rate between young people, that is to say people under 35 and then 35 and over. And that has persisted now for several weeks, and in fact has grown a little bit wider over time. We are continuing to look at all of the elements demographically that might be contributing to that. We are obviously very concerned about disparities with respect to race and ethnicity. We are very concerned about issues related to in what circumstances people might have been exposed. I will say that with contact tracing, we do try to identify those circumstances as much as possible, but it's very difficult to see any discernible trends that you could point to. So that's the reason that we're encouraging social distancing and facial masking and all those other behaviors in every single situation where people are together, and particularly indoors, and particularly in groups. So that's when we find trends that we can address specifically, such as, for example, differences in race and ethnicity, that is the basis on which we make specific targeted actions. And so, as you know, the Office of Minority Health and Health Disparities has reached out to the 5 counties that have some of those largest disparities, and is working with them separately to do more targeted messaging towards minority youth and people of all ages. And so I think that I agree with you completely about the issues that you've raised. We will continue to obviously follow those demographics and make the General Assembly aware of significant trends as we move forward.
Can I ask, just as a quick follow-up, to the extent that we are seeing this trend towards more younger population being identified with cases, as the state in its public health messaging, the Masks on Maryland campaign and other things, look specifically at targeting younger populations and folks who might have some influence with those younger populations?
Yeah, so the first part of your question, absolutely, which is one of the reasons it's hashtag Masks on Maryland. I was not consulted in the development of that campaign. I think that they had given up on me with anything having a hashtag in it, as being not in part of my common everyday experience. But it is that campaign was in fact very much focused on younger people who are using social media extensively for that purpose. So I would think, so yes, I think that is very much that part of the messaging. As to the issue of spokespeople or role models, I can't speak to that specifically. The second part of your question. You're welcome.
Vice Chairman Roosevelt.
Thank you very, very much. This is a perfect transition because Delegate Jocelyn Peña-Melek and I both represent College Park and have been having extensive discussions with the university and with the city and with the county about our potential situation here, because we say you shouldn't go to places with large groups, and we're talking about having tens of thousands of students coming back to college campuses. And so the fact that people are understanding a little better the dangers to young people and the dangers that the transmission by young people can spread, I think is long overdue. I was very pleased to hear you talk, and I'd like you to clarify a little bit more, that the policy is now promoting testing on demand. Okay, that's terrific. I mean, that's a huge breakthrough from my point of view. One of the things we've learned in College Park, because the university has been very interested in doing widespread testing, and the question becomes, kids who go to the university, people who work at the university have health insurance. The question is the health insurance, people say the testing is free. Well, the testing isn't free if the health insurance doesn't cover it. And therefore we've had discussions with the insurance commission, with a whole variety of people. And essentially there's this open question, and maybe you've resolved it. That's where I'm going with this, that evidently up to like 2 weeks ago, the insurance companies would not pay for the cost of testing unless they were medically necessary. And medically necessary was related to symptoms and was related to doctor's orders. But you can't do mass testing, which is what they did so successfully elsewhere in the world, if you have to wait for the doctor's orders for the symptoms. So my question is, have you now resolved that issue so that the insurance companies should be, will be, have to be paying for the full costs of testing on demand?
Mr. Vice Chair, I cannot for a fact tell you that I know for certain that there has been a determination by every insurance company that they will pay for testing on demand. And I recognize that, and the department recognizes that it is a very important issue. It is clearly something, it is not part of my bailiwick, but it is something that the department is very aware of, very conscious of, and very much part of our discussion about the issue related to all kinds of groups, not just students, but pretty much everybody. So I appreciate what you're saying. I cannot, unfortunately, assure you, I can't give you an answer to your question with any detail. That is a discussion ultimately that has to take place with the Maryland Insurance Administration.
Well, I appreciate that. I've had discussions with them, but it gets a little circular because they say that it's the health people who determines what's medically necessary. So I'd appreciate you taking it back as to whether the health department can make that determination and help the insurance companies do the right thing, or whether it's something perhaps the governor needs to issue an executive order on.
Thank you, Mr. Vice Chair, and I will take that back to the department.
Thank you very much. Thank you, Mr. President.
Vice Chair Peña-Melnick.
Thank you, Madam Speaker. Good morning, everyone. And Dr. Mitchell, it's always nice to see you. Can you provide us with a list of the local jurisdictions that rely on your contractor for contact tracing? If you could give us that to the group offline, that would be great. And as you provide that list, how many people have been hired? How many are Blacks, Latino, Asians, or others? That's the first question, if you will be so kind and get back to us. The second one is, as you're aware, COVID-19 has disproportionately impacted the state's African-American and Hispanic populations through the rates of infections, hospitalizations, and death. Do you have an outreach plan for the Black and Brown community, which is really needed? Any enhanced messaging. And this is sort of related to that. Maryland does not have race data for approximately 18% of COVID-19 cases. Is there a plan to require health systems in our state to collaborate to enhance our data collection efforts to fully capture that, what includes self-identification of race, ethnicity, and language? Thank you.
Thank you, Delegate Peña-Melnick, and it's always a pleasure to chat with you. So let me, or Senator, I should say, let me answer these, I think, in order. First, with respect to the list of jurisdictions that use NORC as the primary contact, and I should be clear here, all of the local health departments are engaged in some way in contact tracing. The difference is whether NORC, the contractor, does the first call and then refers the follow-up to the local health departments, or whether the local health department does the first call and takes the entire responsibility for itself. So all of the local health departments are, to some extent, very much involved in contact tracing. With respect to hiring of workers who are Black or Latina or Latino, I think, are you referring to, just so I'm clear on this, are you referring to those employees of NORC or those employees of local health departments involved in contact tracing? I just want to be sure I'm answering the question.
I would say the employees of both.
The employees
As you know, this has impacted the
Sure.
African American and Hispanic community, and you need a trusted source, right?
Yeah.
People that look like you, and we know when it comes to public health, it makes a big difference.
Yes. So, so thank you. So we will provide that information. So with respect to outreach, there are several different answers to this question, and let me go through and talk about those a little bit. So the Office of Minority Health and Health Disparities has been leading the department's effort to engage with minority communities and COVID-19 across the state. So there are a couple of different aspects to that. The first, and one of the most important, is for Prince George's County, Montgomery County, Baltimore City, Baltimore County, and Anne Arundel County, those 5 jurisdictions, which had the largest numbers of cases, minority cases, submitted proposals to the Office of Minority Health and Health Disparity, and were each awarded $200,000 to look at to address specifically the issue of engagement with minority communities in those jurisdictions. In addition, there is a statewide, separately, a statewide multimodal communications and messaging package that is focused on these 5 jurisdictions, but also runs statewide, and is focused on, again, engagement with and follow-up with those communities in order to make sure that the department reaches them and provides messaging on prevention, on testing, on contact tracing, and on follow-up associated with that. So those are some of the things that are very much part of what we are trying to do across the state in concert with and in very close cooperation with our local health departments. There are other efforts as well, but just to give you an example of some of those that are amongst the most significant.
All right,
so I hope that's helpful.
Yeah, and you did not, if I may, you did not answer the.
Sorry, my apologies. The 18% question.
Yes.
So I can speak to that a little bit. I know that the Office of Minority Health and Health Disparities, the Deputy Secretary for Public Health Services, and the CRISP has been very engaged with trying to improve, to the extent that we can, data on race and ethnicity within the testing and lab reporting system. There are some limitations to what we can do in terms of people's willingness to report that on lab slips or requisitions. But we are very much trying as much as possible to improve those data so that we have as complete a picture as possible of who is being affected.
Thank you. And just a quick follow-up, a lot of states are doing a lot better than Maryland, actually requiring that information. So I know it's definitely doable. And can you just give us offline the engagement packaging regarding the Black and Brown communities? Can you tell us what that is? Because I have not seen it in this community from the state, and especially in the Black and Latino community. And thank you so much for the consideration.
No, we would be delighted to do so. Thank you.
I believe we have two final questions. Chairwoman Kelly.
Yes, I'm very concerned about school districts and MSDE planning for resumption of public schools without, it seems to me, sufficient input from those who know about the health needs and the public safety needs of the children, however it is that we're going to create school for the fall of this year. I'm thinking of kids who teachers know and social workers in schools know have a history of being abused or neglected. I'm thinking about kids whose parents are essential workers, so that the 9-year-old is at home alone, since we also closed down daycare centers and many essential workers can't afford them anyway, so that the 9-year-old is now the caregiver for the 4 or the 5-year-old. I'm thinking about the depression probably, and the state of mental health of kids in those conditions if we start off with a new school year with these kids at home. I'm thinking about kids who live where there is no broadband, not only on the Eastern Shore, but in broad expanses of Baltimore City. So if we're talking about internet and digital education, what are we going to do about it? And then finally, it occurs to me that in places like Baltimore City, where kids often have to walk to a neighborhood school, and that can be a 5 or 6 block walk, or they walk for that far before they catch public transportation. And I've seen public transportation buses with signs saying essential workers only, with young school kids be on the same public buses with essential workers who go to places where there's a great likelihood they might be infected. So those kinds of things. What would you tell MSDA to consider from a health perspective of the kids? And should there be more public input? Should there be meetings, whether online or flyers sent out or surveys done to find out more about the health needs of the children before we come down with a plan that for an entire year might not work well after the kids have been out of school so long already? Thank you.
Madam Chair, thank you for the question. I would say we have been and continue to be very engaged with the Maryland State Department of Education at all levels regarding planning for reopening of schools in the fall in whatever form that takes, and have continued to be engaged with them on many aspects of their planning, particularly with respect to health and safety. The questions that you've raised, many of them are actually outside of our purview. And so, for example, for questions related to transportation and other issues, I would have to refer you obviously to the Maryland Department of Transportation and MSDE for further follow-up.
I know you won't get to make the decision, but is there guidance that you could give to them? I'm sure there are many variables. I've spoken with the state secretary within the last week myself about these concerns. I think a lot of it is not on the agenda. What would you suggest they ought to consider from a health and safety perspective for the kids?
So I can say, Madam Chair, that we have been very engaged with both the State Department of Education and with the Department of Transportation on issues related to health and safety as it pertains to each of their agency responsibilities. We see that as our role, which is to provide the best health and safety input that we can as they make decisions about how to conduct their operations. We will continue to do that. For example, with respect to the Department of Transportation, we have provided input and guidance related to their operations and public transportation questions. With the Department of Education, we've been extensively involved on issues related to school health, to other operations as they relate to what the MSDE is planning for reopening.
Could you share with us just a tiny bit of the guidance that you're giving them?
So I think that what I would do is with all respect, I would defer to the Department of Education as to how it ultimately is making these decisions. I can share with you, we have a group that working with the school nurses and the school-based health facilities on a regular basis, and has been meeting on a practically daily basis for months to talk about planning for reopening. So I know ultimately that those decisions in terms of our providing the guidance to MSDE, in terms of the implementation, obviously MSDE will make the final decisions related to the reopening plans. But I am happy to pass along your questions to our Office of Governmental Affairs related to the question about the kind of guidance that we have been working with them on in more detail.
I believe we have one final question from Senator Lamb. Before we jump in, I just want to reiterate the chairwoman's point, both as a public official, but also as a dad of 2 kids, that there are unbelievable questions and Maryland families are desperate to have some guidance. I think school districts are desperate to have some guidance as well, to the degree that the state can take a more active role in providing that guidance publicly and giving some level of confidence to parents about what they should be considering with their kids and what what the plan is for Marylanders. I think I can't urge that enough on both a personal and public official basis. Senator Lamb.
Thank you, Mr. President. Cliff, good to see you again. I just had a question and wanted to first start and touch on the cost issue of these tests. I think it was Delegate Lukey that had mentioned that it wasn't clear if these tests could be billed back to insurance or not. I know in the bill that President Ferguson and I had passed right before session ended to address the COVID-19 pandemic, that we had empowered the governor with authority to not charge for these tests. And so I think to that point, I think this could be fairly easily cleared up by the governor with regards to that authority to not have those tests billed to individuals. To the point that you had made earlier about the positivity rate in decline, and I think that is positive. I guess my question has to do with the positivity rate itself, that it's really dependent on many different factors. And, with testing on demand now being available to Marylanders, that will essentially increase the denominator for the positivity rate. So therefore reducing the positivity rate itself in general, right? And if you only tested, for example, if you only tested symptomatics, your positivity rate would go up. Mm-hmm. And conversely, if you only tested asymptomatics, or if you allowed for greater testing on demand, your positivity rate could actually go down. And neither is wrong, but the positivity rate is highly dependent on the population being tested and thus the criteria that's being used for testing. So while there's been a lot of attention being given to the positivity rate, would it not, from, say, like a public health or epidemiological perspective, be potentially more informative to use a rate that's more set based on criteria like hospitalization or ICU or the death rate? Because, for example, with the hospitalization ICU rates, you're assuming that the folks that are admitting people in the hospitals are using the same criteria, right? So the denominator would essentially be the same. So I think it's just important, and I know you've been citing other rates too, but to bring up the fact that a lot of people get hung up on the positivity rate, but that's really dependent on the denominator.
Senator, I could not agree with you more. First of all, I don't think I could agree with you more, or could not agree with you more. But I agree with you about the potential issues with the positivity rate, and I think that that's one of the reasons, obviously, that we don't look just at the positivity rate. It is dependent on who and how many are tested, as you indicate, and so the hope is that what we are doing, and I will say this. When we look at the positivity rate, we look at it overall for the state. But one of the things that we look at internally is the jurisdiction by jurisdiction trends in positivity. And so two things I think are, as you say, worthy of attention. The first is we don't know in which direction the bias goes with respect to who is likely to ask for and get a test. And so and one of the questions that will inevitably come up is if people are getting tested because they think they've been exposed, even if they're asymptomatic, and they're positive, that is a very good indication, I think, of the direction of spread, particularly in asymptomatic individuals. And we would certainly look at that as an indication that there's more spread than we think there is. And so it is one of the factors that can be useful, but we don't want to be misled by it, particularly if it's going down. But it really is going down because we're just testing everybody regardless of the reason for the test. So I agree with you about that part. I also agree, obviously, that one of the advantages of using hospitalizations is that it is relatively immune from bias in who gets tested, because presumably people who come to hospital, if that percentage is remaining stable as a function of the percentage of people who are infected, it should reflect or be at least another indicator of the true rate of infection in the population as a whole, assuming that we haven't changed our criteria for who gets admitted and hospitalized. So I completely agree with you that it's important to look at all of these data. We try to look at all of these data and be as objective as possible. Obviously, when the federal government chose positivity rate as an overall indicator of how things were going in the country as a whole, we try to report that as one indicator, but it is not by any means the only indicator reported to the governor on a daily basis, and not the only indication that he looks at. With respect to your first question about the governor's decision by executive order, obviously I would defer to the governor in terms of his decision about whether or not to adopt that strategy. That's fortunately or unfortunately not my decision.
Yep, thank you. The first part was just a statement, not a question, but thank you, Cliff.
Thank you, Senator.
All right. Well, thank you, Dr. Mitchell. We appreciate your time and your thoughtful feedback. We greatly appreciate the work that you're doing, and thank you for being here with us today.
Thank you, Mr. President. Thank you, Madam Speaker.
Excellent. All right. Next up, we have someone who has been with us previously, Dr. Justin Lessler, who's an associate professor at the Bloomberg School of Public Health at the Johns Hopkins University. And one of the reasons that Dr. Lessler was last with us about 2 months ago and provided some models as to what the potential projections could look like with the spread. We asked Dr. Lessler to provide us some updated information as we see what's happened in Maryland over the last 2 months and across the country. And so look forward to those updated models. Without further ado, Dr. Lessler, thank you for being here with us today.
Thank you. Okay, yeah, so I'm gonna just talk a bit today about intervention impacts and future directions, and sort of give an update on what I said last time, with maybe more of a focus on what has happened and what will happen, as we're in a very different place in the epidemic than we were there. Next slide. Yeah, so just as a reminder for last time, I presented some planning scenarios based on various things that could happen. I very much emphasized that these were planning scenarios to help think about the problems of going forward, and not really focused on necessarily having the being forecast per se. But that was a different time. We didn't have much data, and also we didn't have much to look back. So today I'm going to come back to that a little bit at the end, but I want to focus a little more on sort of what has happened. Okay, next slide. So the first question I want to talk about is how things have progressed. So if we whereas before we were trying to, and this is just an illustrative figure, I know it's complex, but whereas before we were very much trying to project forward based on little data, now we have, since that time, we have several months of data that can that we can use to start thinking about what actually happened and how that relates to the various possible scenarios that we had before. And how we do that is we, simulate tons and tons of different scenarios. That's all these little gray lines on this picture. And then we compare them to, in this case, so various aspects of the actual reported data. For instance, this case is the red, the blue dots. And we can use that then to estimate various aspects of what has actually happened over the course of the epidemic. So moving to the next slide, one of those key things to estimate is the reproductive number, or the reproductive number over time. And just as a refresher, I'm sure you all have heard about it, but just to refresh your memory, the reproductive number is the expected number of cases that an infected individual will cause in the population under current conditions. And when that number is above 1, you cause more cases in the population than are currently infected, and the epidemic grows. When it's below 1, cases fail to replace themselves in the population, right? So if I only on average infecting a half person, or say every 2 cases only infect 1 additional person, then cases are not replacing themselves in the population, and the epidemic will decline. So, one way to think about control measures, at least if our goal is to bring the cases down, is to bring the reproductive number below 1. So this figure shows the time series of the reproductive number sort of averaging over the entire state, in the sense, so these blue shaded regions capture not just uncertainty, like because of our estimation procedures or anything else, that's like also variation across the state. And it shows how that, after starting out with a reproductive number somewhere close to 2, in late March, as the more strict stay-at-home orders came into place, that our models project that the reproductive number for the most part fell below 1 for most of the state, as reflected by the declining cases. But then it is also suggesting that in many places, since we've entered, as we've entered sort of more closer to phase 2 of the reopening, the reproductive number has increased. I think just to get a sense of like why this is like lagging a little bit beyond like what you're seeing in a lot of the, in major differences in case numbers, I think a friend of mine or a colleague had a good metaphor, is that the number of cases you're seeing, that's how close you are to the wall. And the reproductive number is how quickly you're moving toward it. So you can start moving toward the wall before you're that close. So next slide. Of course, this statewide thing, statewide bit, obscures a lot of variability across the state, and the counties have had very different experiences. And, it did look early in the epidemic, mid-March, that, every county was having a reproductive number above 1, and we are seeing growth everywhere. And just for this figure, I think to think about it, think about white being close to 1, having some uncertainty, blue being good, red being bad and growing. As we've moved forward, for the most part, in most places, at least the mean estimate of the reproductive number fell below 1 or right around 1, with a couple of exceptions. And then as we've entered July, it seems that growth, that there's pretty uniformly some growth across the state, though not necessarily at the speed that we were seeing, and they're still seeing, in another way of saying it is interventions and actions that people are taking on their own are still having appear to still be having a substantial effect, but we're not, we're definitely the models suggest, and the data as we interpret it suggests that we're in a growth phase now and no longer in a phase of sort of stability or receding. Next slide. So another way to think about this is, what we're talking about is intervention effectiveness. And I think there's, some spillover in how people, so when interpreting these numbers, I'd like to stress that there's some spillover in how people interpret or are acting in various times. So these are estimates for a period, not like, for how much the reduction in the reproductive number was during a period. So during phase one, during the stay-at-home order period, we expect that on average, the reproductive number was reduced by around 60% for the state. And given that we think its baseline is around a bit over 2, that is adequate to get the reproductive number under 1 in most places. And in phase one, phase one sort of broadly, if we think about phase one across the state, the reduction we were seeing was actually a little bit touch more in our point estimate, but I'd stress that, within the realms of statistical uncertainty, it's basically the same. We didn't see a huge change right when we went to phase one. And I have some counties broken out here, not necessarily because their actions were different in terms of how much impact things had, it's because their timings were different and how long they stayed in phase one. But you can see around sort of across the board throughout phase one, we were still seeing, evidence was still suggesting we were in a regime of around a 60% reduction in the reproductive number. And then now, now that we've entered phase two, that's dropped down to still a substantial decrease of around 50%, 45 to 50% in how much we've brought down transmission. So you're getting rid of 45 to 50% of transmission that we think would have happened otherwise, but that no longer is enough to drive the reproductive number below 1. We can, so next slide. So then the next question, and this gets to more of the things I've talked about last time, is what happens next. So going to the next slide. And so before I talk about any of our results, I'd like to talk a little bit about forecasting in general. So here I'm showing like this idealized emergent epidemic, right? We have some pre-emergence period, and then there's like after emergence, we're in this pandemic phase where we are now, this red time, and we're responding. We're responding, we're doing short-term forecasts, and then there's like something's going to happen over the midterm, and then eventually the disease is going to, enter its long-term relationship with the human population, let's say. And so next slide. So I like to use the metaphor of weather forecasting for understanding our ability to talk about these phases. And I think this is useful for thinking about what I'm going to tell you now, but also other forecasts you look at. So the short term, this red period, and for our pandemic, I'd think of this as the 2 to 4 weeks type of realm. That's kind of like your 10-day forecast. And we can do that by looking at current trends and the like. We can do that with reasonable accuracy. On the flip side, on the very long term, that's like climate science in general. And if you believe climate science, we can sort of say things like that the given continuous increases in carbon into the atmosphere, we will over the long term see increases in temperature because based on general principles. But that midterm, I think the appropriate metaphor there is the farmer's almanac. You know, that is like, what's the weather going to be the 4th Tuesday of August? We really don't have an ability to say much about that because it's so much driven by random events. It becomes even worse when we're talking about infectious disease because unlike weather, people sometimes will respond to our infectious disease forecasts. And I think, you know, like for instance, everybody saw the writing on the wall that things were going to increase, whether or not they believed the formal models back in, you know, late March, early April, and took action. And that changes what's going to happen. Next slide. Yeah, we won't talk about pre-emergence. That's Nostradamus. So I would also stress that the metaphor that I think when thinking about that short-term forecast, what I could say we could do well to continue the weather metaphor, I'd say don't listen to any one model. And I absolutely include the model we make, we do among that. I think it's good for some things, but I don't think it's good for everything. What you want to look at is the ensemble or the combined knowledge of a bunch of different models, each of which is likely bringing something to the table. And this is how hurricane forecasts work and even our 5-day forecasts work. And this is how how I would suggest where you go when you want to think about these short-term forecasts. And so this is the Forecast Hub. A colleague of mine, Nick Reich, at UMass has been organizing this, but he's doing it in conjunction with CDC. So this information also shows up on the CDC website. But there they take a bunch of models, a whole slew of models. I think they're up to 26. And then next slide. And they and they ensemble them, and that this red line here is showing the ensemble forecast ensemble forecast of those models in terms of projecting forward in terms of here incident deaths, and that is more accurate than any single model and has performed well. And here I'm contrasting it actually with our model, which is in green. And though our confidence intervals, our uncertainty captures what happens, we tend to overestimate how bad things are going to be because we found our model has been a little too responsive to policy changes in the sense that we start thinking things are going to get worse based on a policy change or a change in behavior faster than people actually do. Next. So now I'm going to talk a little bit about the midterm, and I'm re-showing a slide I showed this time. I think when we talk about the midterm, we're really, and even sort of the long term, we're really focusing on planning scenarios, not forecasts, right? We want to give people like you all scenarios relevant to planning decisions and use rough approximations given our best knowledge of disease dynamics, the current situation, severity, to inform those. And often the differences between scenarios are absolutes. And we use a pipeline approach, but I'm not going to get into it this time. Next slide. And I want to leave us with one result from that. So these are a bunch of scenarios I showed you last time. Unfortunately, I was hoping to have updates, but because I had a little bit of short notice for this, so I wasn't able to. We were scrambling to get stuff running last night, but the computer gods did not smile on us, and so we weren't able to update. But I want to emphasize this is a slide I showed last time, and that one of the things I emphasized last time I talked to you is that until you get to this gray area of immunity and of cumulative infections, and that much immunity accumulated into the population, you're not done. So as we successfully control the virus, we are, doing great things in terms of reducing cases and stuff like that, but we're also slowing the rate at which we get to that immunity. and increasing how long we will be fighting the virus. So, and by no means am I saying control is a bad thing. We want to control. We don't want to overwhelm the self-care systems. Less people die when we control, et cetera. But, you know, there's no like magical, unless there's a vaccine, there's no magical thing we're going to do that lets us get out of this without accumulating immunity. And with that in mind, I want to do some simple math. Next slide. That I did last time to sort of show how I think we progressed in terms of accumulation of immunity. Something weird happened in the font here, but so last time in April, I forgot the exact date, but whenever I talked, we had about 858 deaths in Maryland, putting a multiplier for delays for deaths to be reported and assuming a death rate of around 0.5%, which I think has been held up relatively well under evidence. You know, that gave us something like 257,000 infections that would likely occurred within the state, or, you know, around 260, which is around 4% of the population. So in April, we had not accumulated much immunity, and our estimates of R were, you know, if we were to remove all our interventions, we're in this 2 to 3 range still, and there wasn't much, you know, impact of immunity. Since then, you know, like a lot more people have died in the state. And we kind of think because, you know, that's a higher percentage of the people who are going to die based on infections already. So using our same sort of back of the envelope calculations, you know, we would expect somewhere around 812,000 people to had been infected thus far in the epidemic, or something around 13% of the state's population, which is, you know, substantially more immunity than we had before, and is enough to like have a noticeable difference on how much transmission occurs, but it's still nowhere near an amount that if we were to lift lift all of the measures we have in place, both through policy and personal action, that we would have the epidemic under control. So I think we are walking down the road. I think we've, you know, based on our models estimates, the things that have been done have had real and substantive impacts on the course of the epidemic, but there's still a long path ahead of us based on our analysis.
Thank you, Dr. Lessler. While we don't have any questions, I do have one, and would like to go back. If you could, Jake, go back 2 slides to the one that was through January. There's a bit, one more for, yep, right there. Not the approach, the graphs. Yes. So in each of these so in the first 3 scenarios, taking from the perspective that the speaker and I, along with members of the General Assembly, will be looking at, you know, January is the cutoff point here. In 3 of those graphs, it looks like immunity has been reached in the first 3, and the second 3, much less chance of immunity having been reached by January. Given that these are planning scenarios, what are the factors that we should be looking at as we think about what a next session could or should look like? At what point will these planning scenarios help us to kind of get a sense of where we are?
So I think, so 2 things. One is, as I said, these are a little stale, right? And I wasn't able to update them in time for this meeting. But I think that I feel like these curves are good to think about in terms of, we can think about as we get more and as we send updates, they're telling us sort of how far along this path we are. And that calculation I did about underlying immunity, like you can take that line and draw it out here. I guess I can't really draw on the screen, but it's about halfway up, you know, it's sort of halfway up this graph. It's, you know, noting that this is a scale where that isn't halfway there. So we are, you know, I think we are progressing in more of these right three scenarios where if, we don't like accelerate how quickly and how much cases we see, which looks like we are, but if we weren't, we probably would not have not have immunity by January. And I think we're trying to roll out some more of these, but I think the general message is that if you avoid surges of cases that will overwhelm the healthcare system and keep things at the levels that you want, models agree, not just our model, but other people's models agree that you're still going to be dealing with this in January. You're not going to be over, you're not going to be over the herd immunity threshold. All of those scenarios where we do get over the herd immunity threshold by January include surges that are larger than I think anyone here wants to tolerate.
It does look like we have two questions. Just would ask, it looks like two senators, if we could ask very, very briefly, because we're running a little bit short on time. Senator Rosapep.
Sure, thank you very, very much. The immunity issue is the thing that concerns me. My impression is there's enormous debate about what immunity is, when we'll know what immunity is, how real immunity is, how serious immunity is. So I'm curious as to what is the assumption you make about the definition of immunity for these purposes?
Right. So here we are, and this is right, we're projecting over the midterm. So here we are assuming that immunity is what we'd call sterilizing or protective in the over the time period of these models. So that is that over the next year or so, if you're infected over the next year or so, you're not susceptible to a significant infection, and you're less, and that would let you transmit.
You're assuming it would last a year.
There is a lot of debate about that, right. But I think most of that debate is about longer time periods, right? There is debate over the short time period, but I think where the real uncertainty lies and where we know the timeframes where we know other coronaviruses circulating in the human population can reinfect people, that's getting to a year or 2 years. And I really, I wish I could have some answers for you, but I really think the data, we need a lot more data before we can say anything really meaningful looking 2 to 3 years out because of that uncertainty.
Thank you.
Senator Lamb, very briefly.
So thank you, Mr. President. Just two brief questions for you, Dr. Lester. You showed a slide earlier that had the transmissibility rate and also some banding in between. And that slide showed that we were for a period below 1, and then after the early part of June, we jumped up above 1. Can you speak to why that occurred? And then one other quick thing follow up after that.
Yeah, so our model, in contrast to some other models, right, like, so some models take a secular approach to, a secular approach to estimating the reproductive number. And if we'd done that, those lines would have been quite smooth. Our model, and I think this is both an advantage of a limitation of our approach, is we tie all changes to policy changes, right? So we are looking under different regimes. So that jump up corresponds to the timing of people moving, or not people, but counties moving from different phases of their response. So I think in general, it's a move from phase 1 to phase 2.
Got it. And then the quick follow-up about the slide that we're looking at now, the 3 that we see on the right, or on the left rather, that would probably mean overwhelming the healthcare system significantly, right? So to the extent of what we saw back in April in New York City, where it was chaotic, and what we're seeing now in Houston, which is essentially the same, that would mean overwhelming the healthcare system in any of those 3 models to the left. And I guess what your point is that the goal of all of this is to lift restrictions to a point where you don't overwhelm and crush the healthcare system, but be able to fine tune that. So when you see cases going up and approaching the limit of the healthcare system, to put restrictions back in place and to keep that threshold just under the capacity of the healthcare system. So while you're building as much immunity as possible, you're not, overwhelming our hospitals, right?
I'd say that that's one, yes, that is a way to think about a goal. I don't know that you necessarily want to be right there, but I think my point is, I'm not going to I don't want to sort of, go too far in saying what should be done, but I can say that like your options are, right? If you do completely stop transmission, right? Absent a vaccine, and hopefully maybe we will have a vaccine by the early next year, but I wouldn't, depend on that. I would never make a policy depending on that. But absent a vaccine, like you're just kicking the can down the road. Now, there may be very good reasons to kick the can down the road. Maybe you get a lot better at treatment. Maybe we'll get some with some new drugs and stuff. Maybe we, maybe there can be a vast expansion of, the ability to, like what was talked about earlier, isolate people out of their households or something like that. So maybe you have a reason to kick down the can down the road, but you're not solving the problem. Only in this middle path where you don't do you not overwhelm the healthcare system, and you let the disease move somewhat, will you eventually accumulate enough immunity to sort of get out of the woods? But as the previous questioner mentioned, right, we don't actually know if that's going to get us out of the woods long term, because we don't know exactly what's going to happen with immunity. Though we're pretty confident at least second infections are likely to be less severe. And, and you are making a decision there that will involve people getting infected, and some of those people will get sick and die. So, that's why I don't necessarily want to say which path is the right path. It's just, these are the trade-offs. There isn't going to be a free lunch unless the vaccine comes along. So, you're going to have to pay the price in immunity at some point, and how we choose to do that is a difficult question.
Right, but potentially more people could die on the three on the left.
More people will die on the three on the left. If you overwhelm the health, so there's two reasons. One is if you overwhelm the healthcare system, care will get presumably worse and more people will die. There's another reason, and that's if you think about the epidemic, and at the peak of the epidemic, that is when R falls below 1, right? But there's still a lot of people infectious. So the more people who are infectious, when you start going down, the more cases you get that you don't need, is a way of thinking about it. So if 50,000 people are infected and we drop R down to like 80%, 0.8, so you get 4 infections for every 5 people infected, that's 40,000 people infected in the next generation. Whereas if you did the same thing when there only 10,000 people were infected, that's only 8,000 people infected in the next generation. And so you really reduce cases by reducing the size of the peak. You reduce the overall number of people ultimately infected. So it isn't just the healthcare system, it is the number of people you ultimately infect that you can help by doing this flattening the curve or mitigation strategies.
Great, thank you.
Thank you very much, Dr. Lesser. We appreciate you being with us.
Thank you for having me. It's an honor.
Now we have our third presenter, and it's Joe DeMatteis, President of the Health Facilities Association of Maryland. He is rejoining us today to give an update on the efforts in our nursing homes and where we stand today. Thank you, Joe, and you may proceed.
Madam Speaker, Mr. President, thank you very much. Joe DeMatteis from the Health Facilities Association of Maryland. I wanted to provide you just this very brief update to leave time for any questions we might have. I wanted to let you know that currently our estimates is that we think there are about 60 nursing homes with COVID-19 outbreaks in Maryland. That's at least one case. Madam Speaker, just to make sure, you're hearing me right now, yes?
Yes, yes.
Yeah, so we estimate about 60 nursing homes currently with a COVID-19 outbreak, and that's at least one case in those centers. There are a few centers that still have hotspots. Those would be centers that have positive testing rates, let's say at 20% or lower, rather than in the single digits, a handful of those. Back in April, when we were at the peak in our part of the sector, we were seeing positive test rates more in the 50 to 60% range, with a large number of those being asymptomatic. So that sort of gives you a sense of where we are today versus where we were at our most recent peak in April. There is absolutely a correlation between how hot a community is, how hot a zip code is, and a nursing home or assisted living or a healthcare center in that community. And there is absolutely a correlation between the social determinants of health and healthcare disparity, as well as pre-existing conditions with regard to the uptake of this virus, whether it's in a nursing home or in the community at large. Until we have a broadly available vaccine, we are going to be fighting COVID-19 in our sector. State weekly testing in our sector continues now for nursing homes provided and logistically supported by the state. That's a great thing. We have seen, because of the increases in other states and the uptick in COVID-19 in other states, believe it or not, that has put a strain even here on lab capacity because of regional lab capacity. So the amount of time that we're waiting to get a test result is up again. It was obviously very high in April. You waited longer in April. You waited shorter last month, and now it's back up again. So it's not uncommon to wait, 3, 4, 5, maybe a week for days or a week for the test results. What we want to avoid is not becoming New York, where it is not uncommon to do a weekly test on a Monday, be required to take the test again the next Monday before you actually have the test results from the first test. Massachusetts has gone to every 2-week testing and then more frequent testing based on hotspots. Obviously, from a sector perspective, we would like the state government to continue state logistically supported funding and testing, both in nursing homes and assisted living beyond the August 1st deadline. To recap a couple of quick points that came up with Senator Rosapep and others, Vice Chair Jackson. First to Vice Chair Jackson on PPE. Nursing homes are still not getting the 100% of their allotment. So when they call their supplier and say, I need X number of gloves, X number of masks, X number of gowns, they are still on reduced allocation. There just simply still isn't enough to get everything from one supplier. So prices are up because you have to go to secondary providers. We can expect glove prices to go up this summer because many factories have been retooled to make masks, but it is much, much harder to retool to make gloves. And we are tracking on syringe shortages in the future as we approach flu season. To Senator Rosapep's point, a bunch of insurance carriers are not covering the tests unless there are symptoms, and we know COVID is asymptomatic, and that's a problem going forward. So, Madam Speaker, Mr. President, that's my quick update. I hope I left some time for some questions.
Yes, you have. Thank you. Majority Leader Lukey.
Thank you very much, Madam Speaker, Mr. President. Mr. DeMattis, I know one of the conversations that had been happening with the facilities was a conversation with the administration about increasing the Medicaid reimbursement rate to help cover some of the costs of COVID. Can you update us on how those conversations are going?
Yes, thank you for asking that. I appreciate it. Let's give a national update and sort of bring it back to Maryland real quick. About the first congressional support for the Medicaid rate was the first thing Congress did, and they did that in March. And then, of course, there's the CARES Act funding that centers have received, as well as states have received directly from the federal government. So fast forward, the Medicaid supplemental funding, as you know, is structured in such a way where the state can use those funds to backstop revenue shortages. They cannot use the CARES Act funding in that way. So last 2 points, about half the states have used either the enhanced Medicaid funding or the CARES Act funding to increase rates for COVID. Most recently, Pennsylvania and Texas in the last 3 weeks have increased nursing home rates to fight this unprecedented pandemic using CARES Act funding in the state. Again, Maryland is one of the half of the states who have done nothing to enhance the rate. And in fact, one of the potential future cuts in Maryland that's been identified has been the 4% rate increase that the General Assembly passed last 2 sessions ago, or last session, excuse me. So no rate increase in Maryland. And quite frankly, we're fighting to maintain the 4% increase that was advanced by the General Assembly pre-COVID.
The bottom line, the facilities haven't seen an increase like they've seen in other states, and the increase that was projected under the General Assembly's decision-making is still under threat.
That is correct. That's the bottom line.
Thank you.
All right, Chairwoman Kelly.
Mr. DeMattis, I know that you are nursing homes and not assisted living, but since the department hasn't been regularly reporting the two separately and disaggregating for each category, what can you tell us at this point about the situation with assisted living? In many cases, you do share campuses where the larger ones are concerned, but we know that lower income people tend to be in assisted living. They are less well regulated. What can you tell us to give us some kind of an update there?
Well, I worry, thank you, Madam Chair. I appreciate the question. I worry about especially small assisted livings, but assisted livings in general. They are not structured the same way. There's some advantages and disadvantages of being in assisted living. One of the advantages relative to COVID is less come and go, potentially less exposure, lower staffing, right? So you've got less people potentially coming and going. But one of the dangers on assisted living is that they are not allocated in the same way in terms of PPE. They're not trained the same way in terms of donning and doffing PPE. So PPE is, I think, a much bigger challenge for assisted living. I'm encouraged in our behind the scenes communication with the Department of Health to become more assertive on the assisted living side. Even though assisted living for HFAM is a sweet spot with the larger providers in terms of membership, we've been working with smaller providers and with the other associations on it. So I will say that if I had to track on 2 things right now on assisted living, or let's say 3 things, I'm most concerned about the small ones, because the small ones typically care for people with pre-existing conditions who are more susceptible to healthcare disparities and social determinants of health. And this disease likes to attack those folks more. So that's a big problem. And secondly, I'm concerned because we haven't ramped up testing in assisted living to the extent that we've done in nursing homes yet. And then finally, I'm concerned about PPE in a world where there still isn't enough to go around. So I'm concerned about assisted living.
Thank you.
Vice Chair Pena-Melnick.
Thank you so much, Madam Speaker. Thank you so much, Joe. It's great to see you. And thank you for always taking my polls. I have a question regarding the dashboard and the state reporting. There's no reporting for facilities that have 10 or less residents. Do you know why that's the case?
I do not know why that is not the case, but again, I think that when you consider healthcare disparities in Maryland and the social determinants of health, by the way, not just for the patients and the residents, but for the workforce, I think it's especially important that we capture that data for smaller centers. There have been some positive media coverage of Maryland Baptist Home in the city and how they've very positively managed the COVID-19 pandemic. And there's actually some upside and downside to that. The reason really that they've managed it so well is that they are unfortunately very isolated in Baltimore City. So they're in that particular small community, they're kind of an island unto themselves. And we know that relative to that facility. But we don't know that relative, for instance, to other facilities in the 21215 zip code as an example. And so I think we need that reporting is the short answer.
Thank you so much. Thank you, Madam Speaker.
Senator Rosebeth.
Thank you. And thanks a lot, Joe, for joining us. On the PPE thing, big picture, are the nursing homes basically getting PPE from the state? Are they basically getting them in the marketplace themselves? Or are you doing bulk buying for them? I'm a little unclear about what the market for.
Yeah, no, I appreciate that. So the three associations, HFAM, Leading Age Maryland, and HFAM, are doing bulk buying for them where we can. So that's the first thing, is that we are assisting our members and doing bulk buying. Secondly, as part of the crisis, the two largest national providers, McKesson and Medline, have been coordinating their efforts with the federal government. And those two providers are the dominant national providers in our part of the sector, and they're coordinating. And then finally, the state is distributing stuff, allotments that they bought from McKesson and Medline months ago, and then distributed via FEMA. But those are typically, and those are, my understanding is that allotment is done here in Maryland at this point. I'm not sure, but we're talking there about a 2-week allotment at a time. So, Senator, let me sort of paint a picture. If I'm a nursing home, how it works for me with PPE right now. I know what I need for PPE, and I call Medline, and I place my order with them. And Medline comes back and they say, I can give you 60% or 70% of your order. Right now, they're holding back. They can't do the full allotment, for instance, on gowns. So they say, I can do 60 or 70% of your order, but I've outsourced another 10% of your gowns from another provider. So that's what I get from my primary provider. Then I, the nursing home guy, have to go to secondary places, sources that I've been identifying all along, Joe Smith's supply company that popped up. And I have to call Joe Smith and say, hey, what can I get from you at a really inflated price? And I get it from Joe Smith. And then if I can't get it from Joe Smith, I've got to say, hey, does HFAM, Lifespan, or Leading Age still have any of that inventory? And that's pretty much the routine for a nursing home at this point. There's very, 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 very little federal or state supply of PPE. It's minuscule.
I appreciate that. I mean, it sounds like the market is deeply broken. And if you have recommendations for how the state can do a better job, I think we would all welcome it.
I appreciate that.
Joe, there are no more questions. I have one last, Mr. DeMattis, rather. I'm sorry for being so informal. Curious whether if you've heard anything about adult daycare facilities had been providing remote services and sort of daily check-ins, and that there had been a recent decision to reduce rates that may make it no longer feasible for those providers to provide those services. Is that something that's on your radar or you've heard anything?
Absolutely. You know, we've had one very, you know, I personally met with the governor on March 5th individually, and then the associations met with the governor on March 10th. And one of our unified asks of the governor on March 10th was that they maintain the rates for adult day during the crisis, even though they obviously couldn't operate because they're not prepared with the amount of their rate to survive a pandemic such as this. And they play such a critical role in diversion from a more formalized setting and a resource to Marylanders. So that was done. But yeah, now that there's talk about reducing rates across the board for Medicaid providers, adult day will certainly be one of the first provider groups that are not able to continue these remote services. And that's going to be a problem. And we're absolutely tracking on that. All three associations are working together on it. So thank you for the question.
Thank you, Mr. Mattis. Appreciate your presence.
Thank you, Mr. President.
I think with no other questions, ends our presentation today. And I want to thank President DeMatos for your information and everyone who participated, all three speakers, as well as members' questions to our three presenters. I cannot stress enough that we need to all continue to model responsible, safe behavior for our constituents. We are seeing the results of poor leadership in other states. Maryland must remain a leader in the fight to contain COVID-19. We will be back in touch about the date of the next meeting. Until then, I ask everyone to stay safe. Mr. President, your final thoughts?
One final update. Thank you, Madam Speaker. I echo every comment that you made during this presentation. At the beginning, requested that the governor make a decision on the elections. It appears that about 45 minutes ago, that decision was released. The governor has put forward a letter to the State Board of Elections exercising option 2, so having all polling places operational with all early voting and absentee ballot applications be mailed to voters, not the ballots themselves. So that was the decision. And so boards of elections will now, I believe, be on the effort of trying to staff a full election in November. When we have more information, we will be sure to pass it along. In the meantime, stay safe, wear your mask.